We are live, sir.
So good evening, everybody. Today we are here and we are very proud that and welcome to the Eastern Journal longevity meeting on management of ALK rearranged NSCLC in first line. We are very proud that we have 5 KOLs from the Eastern India, and they are the who's of oncology field, and they have immense contribution in oncology field. Today they will discuss regarding the new updates on ALK rearrange space of the lung cancer, and what are the future and what are the current therapy is available on that area. So without wasting much time, I will go for a faculty introduction, and then the meeting flow will be like after that Dr. Chandrakant will just set the context of the meeting, and then we have a presentation, the case presentation from Dr. Arvind Kumar from Patna, and then we have the panel discussion which will be moderated by Dr. Chandra. So let me share my screen. So hope Vishwamitra, hope my screen is visible. Can you confirm?
Yes, it is.
Yeah.
Please go ahead.
So welcome all again, and we have 5 eminent oncologists and eminent speaker in today's meeting. So I'll introduce them one by one. So Dr. Chandrakant MB, he's a senior medical and hemato-oncologist in Kolkata. He is working as a medical oncologist in Narayana Specialty Hospital, Kolkata. He has awarded gold medal for acquiring the highest score and the best academic performance in DM medical oncology at TMH Mumbai. Dr. Chandrakant MB also involved as a principal investigator and co-investigator in multi-center clinical trial in oncology. He has participated in various international and national conferences as faculty. He also contributed. His contribution are immense in the field of the oncology, and his research articles have been published in many national and international peer-reviewed journals. Welcome, sir, in today's meeting. Then our next faculty is Dr. Arvind Kumar. Sir is a director and consultant medical oncologist of the Buddha Cancer Center, Patna, and he is associated with many national and international clinical trials as a co-investigator. He has participated in many national and international conferences as a faculty member of that meetings, and his contribution is immense in the field of oncology. Welcome you, sir, in today's meeting. Then our next speaker is Dr. Moses Arun Singh. Sir is a consultant clinical oncologist in Tata Medical Center, one of the eminent cancer center of Eastern India and India. He has training in clinical oncology from Leeds Cancer Center, United Kingdom. Dr. Moses has many publications in national and international peer-reviewed journals, and he has been principal investigator and co-investigator of many national and international multi-center studies. He has been associated with many national and international conferences as a faculty. His contribution to the field of oncology is also immense. Welcome you, sir, in today's meeting. Now our next speaker is Dr. Amit Sharma. Sir is a consultant medical oncologist in HCG Panda Cancer Center, Kotak, Odisha. He has been participated in many clinical trials, and he has been participated in many national conferences as a faculty. He has many publications in peer-reviewed journals. Welcome you, sir, in today's meeting. And our next consultant is Dr. Nabo Kumar Kalita, consultant medical oncologist. Sir, Dr. Kalita is a consultant medical oncologist of State Cancer Center, Guwahati. He has many publications in peer-reviewed journals, and he has been attended as a faculty of also and presented his papers and posters in many national conferences. Welcome you, sir, in today's meeting. So I'll stop my presentation here. Sir, I welcome Dr. Chandrakant to take over the meeting from here. You sir, now the dice is on you. You just set the context and start the meeting, sir. Thank you.
Thank you so much for those kind words and kind introduction about all of us. So as we have already come across multiple longevity meetings initiatives by Pfizer, this is another ALK longevity meeting. The name is very apt, where after the introduction of these new molecules, the long-term survivors have increased. It has actually increased the longevity of our lung cancer patients. So the sequence of today's presentation will be Dr. Arvind, who will take us through the data of LORLA and ALK positive space. After we look into the data, the pros and cons, once we contemplate, and we will have a case-based discussion by Dr. Arvind, and then we can have a mutual panel discussion and figure out what are the patients in whom we can place these molecules in what sequence and what are the challenges in the present day. So with this in the background, I would invite Dr. Arvind Kumar to take up and share his case-based discussion in this ALK positive space. Thank you again, all of you.
Hi, good evening.
Hi, good evening, Dr. Arvind.
Can you upload the Pfizer people? Can you upload my slides? Someone from Pfizer.
Sir, we are trying, sir. Actually, Dr. Amitabh, our AMA, is trying. He has facing some challenges in network. So, Rakea,
Yes, sir.
can you take Dr. Amitabh Dey has joined in attendee? Can you take him in a wave?
What's the name, sir? Faso's name?
Amitabh Dey.
There is only one attendee in the attendees.
No, that original attendee list. From there you can no.
Mm-hmm. Sir, there is no one in the attendees, sir. Ma'am, did... No.
Sir, 1 second.
Sir, I can share it from my end if you share it. Hello.
Yeah,
1
okay,
second.
I will share. Hi, I am sharing.
Okay, sir.
Is it visible to everyone?
Yes, sir. Just make it full screen, sir.
Yeah.
Yes, sir. It's moved. Perfect.
Dr. Kumar, please go ahead, sir.
Okay. So very briefly, I will be presenting my case. Next slide. Next. So this 48-year-old gentleman comorbidity diabetes. He was diagnosed in Feb 2016 with a locally advanced lung cancer, adenocarcinoma. He's a non-smoker. Treated with that time he was treated with radical CTRT. He was had partial response, and he was somehow in follow-up. Then he had progressive disease in June 2017, and he presented with brain mets biopsy, which was suggestive of ALK positive. Next, biopsy and other means EGFR mutation and other were done. They were negative. Now that time he received whole brain radiotherapy and was started on crizotinib. The patient was well, more or less asymptomatic. But in June 2019, he presented with loss of consciousness and was in comatose state. MRI brain was suggestive of progression of the brain mets with development of some new mets. And that time he was started on serotonin 450 mg OD, and he gradually improved and patient regained consciousness and he was able to do his duty. He is a teacher by profession. He joined his duties. Now again in December 2020, patient again presented with loss of consciousness and he was kept on ventilator. He somehow came to my center on ventilator. Next. So that time we started him on lorlatinib with effect 100 mg OD with effect from December 2020, and patient dramatically improved. He became out of ventilator again. He started doing his job, but somehow in between while on serotonin, his disease has progressed with multiple lesions on the cerebellum. So presently he is stable. No, the disease part is better. It has nearly means very less disease, around 10-15% disease is present, but the neurological deficit he developed and Parkinsonian features, this has made him somehow bedbound. He is not able to do his now routine duties, but other parameters are quite well. He is no other symptoms of progression of disease. And so the plan is to continue lorlatinib till progression. Next. So these are the MRI. See the MRI of brain in October 2020. Actual sequence showing multiple lesions in the left temporoparietal insular regions with right cerebellar region with extensive perilesional edema. And now see the MRI brain of January 2023. Just a patient came to follow a few days before. So axial sequence post lorlatinib showing excellent response. Patient has some Parkinsonian features, cerebellar signs, but the MRI, the imaging, so the disease is in nearly he is in CR, not CR, but near CR. And plan is to continue lorlatinib. And see this magical drug means even the patient was on ventilator. We have lost hope, but somehow we managed 2 years and still going. So we will continue this drug and let's see how it progresses. Next. So this was from sequencing of drugs. See from 2017 to this is 2023 means we have nearly crossed 5-6 years. 6 years we have crossed from, if we take from 2017 June, so 5.5 years with metastatic disease. This patient is doing well, stage 4 lung cancer patients. So I think sequencing of drugs do matter, and I hope this patient will do further fine. Thank you. Hello.
Yeah, I'll stop sharing. I'd like to
Yes.
hand over the session again to Dr. Chandrakant.
Yes. So I think Dr. Arvind presented, I think actually a miraculous case, patient of lung cancer on ventilator, surviving for 2 years. I mean, it is never heard of.
That time, my neurologist colleague said that even to her wife and to me also, why are you taking this case? Send him home. And now the same neurologist is seeing him for last 3.5 years. So really, sometimes we get kicked by these patients.
So in oncology, Dr. Arvind,
Yeah.
Have you seen such molecules? Very rare, very rare.
Yeah,
Brain
yeah,
mets.
very rare. That's why I said,
Brain
no.
mets doing like this. Never.
Yeah.
I think never. We never saw such CNS responses.
Just a couple of 7-10 days back, the same neurologist colleague and we were sitting, and he was really amazed that these things can happen in oncology.
So you never heard of, I mean, you look into any cancer for that matter, brain met responding so well. I think osimertinib and lorlatinib, I think these are the two things which I would really think of to have such great brain penetration. Excellent case. And it is not a surprise because I've also seen leptomeningeal disease having complete responses. So, okay, I think Dr. Arvind did set the context very well, as to what molecule we are speaking about. I think we all should be proud of learning this molecule, one of the rare molecules in oncology, which has such a great efficacy. So let's go through the data of first line ALK positive non-small cell lung cancer. So this is how the sequence of slides are. I think we all know this non-small cell, small cell, and then how common lung cancer is and how more women are diagnosed with lung cancer nowadays. This is epidemiology, and these are the different types of mutations, ALK, ROS-MET, and so on. We all want to do NGS other than any other test. And this is the ALK gene testing that we do. So we do by IHC, we do by FISH, and now NGS, and so on. So this is how the ALK looks like. And again, I will start with Dr. Moses. Dr. Moses. So, sir, in your practice, if you do a core biopsy from the lung, do you do a ALK IHC at all now? Or you do EGFR by PCR, ALK IHC, PDL1 by IHC, or you send the block directly to the Oncomine NGS, what you have in your institute? So how do you go about ALK testing in your place, sir?
Yeah, so I mean, till recently, till we have the Oncomine NGS available, we were doing the EGFR, ALK, and ROS1, EGFR by PCR and ALK and ROS by IHCs. But I have moved on, at least for my patients, 100% of them, I'm putting them through the Oncomine NGS. I find it much more preferable because it picks up other rarer mutations as well. So it saves time as well. So that's my preferred method now.
So if you compare and contrast NGS and IHC is quicker. The NGS takes a lot of time.
I know.
So would you? I mean, IHC is something very quick. Yeah.
If you see all the mutations put together, I think NGS is a better turnaround time rather than doing it sequentially and waiting for each and every one. Yeah.
True. So what we are doing, like we have in-house we have EGFR, ALK, PDL1, and ROS. ALK, ROS, PDL1 is by IHC, and EGFR is by PCR. And then we send the tissue out for outsourcing. The problem is the tissue is inadequate majority of times because you have exhausted doing all this. So I think, as you said, sir, I think we need to have a change of practice. Sort of NGS should come upfront in the mind, and we must counsel the patients to be patient until we get it.
Yeah.
If the patient is really deteriorating, then you can put them on some chemo if they're really symptomatic. I think that's the way we need to look into in the present day, rather than wasting these tissues for sequential testing. Okay. So I think we covered all these questions. I think the take-home message should be move towards NGS for tissue and to also capture even the rarer mutations and also ALK mutations with a greater sensitivity. So now I will go to Dr. Navakumar. Dr. Navakumar, are you concerned about the sensitivity of NGS for ALK? You know, ALK sort of is a translocation where they always say RNA NGS should be there. Otherwise, these fusions may be missed. So, do you anytime think of that NGS may not pick up ALK mutation, the false negativity may be there, and I need to do a fish. So, do you look into what type of NGS or is the lab doing? Because RNA NGS is what you will pick up fusion. So, what is your take on NGS as a technique for picking up ALK mutations?
Yeah. So nice, very excellent presentation upfront by and nice initiative. So regarding the testing, so still we are very much preferable with NGS. So because sir have already mentioned that it saves the tissue. So tissue is the main issue. So we all know that at the end of the time, so many of times we face that there is inadequate sample, and and majority of the patient do not want to go for repeated biopsy. So NGS is a preferred technique. And regarding the ALK testing, so generally we prefer to go till now with the DNA technique. So RNA, so though it has high sensitivity, yes, it will be there, but the cost is still an issue for our patient still till now. So if the patient is affordable, then RNA testing is more preferable because it will pick up some mutation, so the sensitivity will be higher. But right now we are doing with DNA-based platform.
Okay, I think those are valid points. We are slowly transitioning towards NGS. Let's quickly move through, and this is how these are the unmet needs in ALK positive space. They're never smokers, and brain mets is a challenge in ALK positive disease because the disease wants to get into brain soon, and the available TKIs do not have greater CNS penetration. So, if you look into the testing for CNS ALK positive disease, NCCN recommends cranial MRI with contrast as a part of treatment evaluation. So, almost all the guidelines are suggesting to do a CNS imaging before start of therapy. So, Dr. Amit, how do you look into CNS imaging for all lung cancers or for all lung cancers with EGFR or ALK positivity? So, how do you have a baseline imaging for CNS in your practice in lung cancer? Dr. Amit?
Yeah. I generally prefer to do MRI for all the patients, to be very honest. MRI brain. Hello.
True. So in an asymptomatic patient, there was a time where we were not doing MRI, right?
Exactly. That was a practice. A few years back, but now we used to do MRI in every patient.
Very true. So,
but if there is if there is MRI is a constant, MRI is not easily available or money is the issue, then I think CT brain is I also do sometimes, but that is only because of logistic issues, nothing else.
True. So I think in the present era, especially in the presence of targeted mutations, we must always do a baseline MRI brain to document what is there inside the brain before we start therapy. Okay. So, and all the guidelines also suggest screening for brain as the preferable way. So this is the compare and contrast of MRI and CT, as Dr. Amit was saying. Only in availability is not there. Cost is a constraint, will do CT. Otherwise, MRI is routinely done for CNS screening. Then coming on to managing CNS disease. So these are the CNS diseases you have. You have local therapies, you have systemic therapies, you have chemotherapy, you have surgical resection. Okay, so now I'll go to Dr. Arvind again. Dr. Arvind, supposing you have a ALK positive lung cancer with 2 small brain metastases, let us say it's around 1.5 centimeters, and the patient is asymptomatic. So how do you treat such patients? Asymptomatic centimeter-sized brain mets in ALK positive lung cancer.
If the patient is asymptomatic, then I think I will go for either ceritinib or lorlatinib without brain radiation.
Okay, when do you want to give upfront SBRT?
Upfront SBRT if the patient is symptomatic, then only.
Okay, excellent. So, as you very correctly said, how much symptomatic the patient is. Only depending on that, a local therapy is required. If a patient is not grossly symptomatic for the disease, then giving a CNS active TKI and avoiding radiation is the way to go. So this is because it is very likely these patients are going to live long with the available targeted therapies. And after a period of time, they will have long-term neurological sequelae if you have given SPRT. Even SPRT to a small area does have some long-term sequelae because if you repeatedly give radiation to those areas, definitely it will have some neurological issue. So therefore, the funda is in an asymptomatic disease, targeted ALK TKI, in a symptomatic disease, local therapy.
But it is very, very difficult to convince the radiation oncologist. In my center, I always had always the debate is going on whether we should treat asymptomatic brain radiation, or always there is a debate.
No, I think as Dr. Arvind very crisply said, asymptomatic, no SBRT, SRS.
Yes,
I mean that's the way to go.
Yes.
Okay, I think this is a few take-home messages which we can go after we complete this, and these are the preferred TKIs. And remember, this is in the alphabetical order than anything else. Alectinib, brigatinib, and dorlatinib. Other recommended ceritinib, and in useful circumstances, there is crizotinib. So SRS, yes, there is a role for limited CNS disease, and this is the treatment sequencing strategies, and this is how it is. You use first Lorla and then chemo. You have a very long progression-free interval, or you use first generation, second generation, and then again you will use Lorla and then chemo. So these are the 2 possibilities which you can have. So coming on to something like rebiopsy, I will again go back to Dr. Moses. Dr. Moses, in an ALK positive disease, do you do a liquid biopsy? Do you do a rebiopsy? So how do you look at these fancy procedures in an ALK positive space?
Yeah, I mean, so till recently, because most of the patients were going on crizotinib or ceritinib as the first line, so I was not usually doing a repeat biopsy. I was just sequencing the treatments once they were progressing. But now, since patients are starting on alectinib or lorlatinib as the first line, I am more and more doing a repeat biopsy. I mean, I don't usually do a liquid biopsy as the first option. I look for a possibility of a tissue biopsy and do an NGS again to look for other pathways which can be targeted. And if only if tissue biopsy is not feasible, then I go with a liquid biopsy.
Okay. So, sir, if you do a repeat biopsy,
Yeah,
Do you send for only ALK or you do a NGS again?
I do an NGS again because I mean I don't think as of now we have evidence to say that this mutation is there. This is the ALK inhibitor to be used. So I just send it for an NGS to look for other pathways which have been triggered as well.
Perfect. I think that is what we all would do because we want to know what is the escape mechanism in ALK positive space. The patient may get a MET
Yeah.
amplification or some other mutation as an escape pathway. So that is important. And this is a summary like ALK positive have more brain metastasis. International guidelines say you must do CNS imaging and sequencing versus giving lorlatinib. These are the two ways of practicing. So, what all you want in the first line? Efficacy, response rate, progression-free survival, overall survival, what's available in second line, and CNS activity. So, this is all what you need to see. Coming on to lorlatinib, this is how lorlatinib is. Selective ATP, competitive, highly potent third generation ALK-TKI, excellent brain penetration to address brain metastasis, improve clinical outcomes with overall and intracranial activity in the ALK positive lung cancer. Upfront treatment can completely suppress or at least significantly delay on target resistance leading to more durable clinical benefit. So this is how different ALK TKIs are there. So you have Chryso, you have Lola, and then you also have Ceritinib and Alectinib. So these are the different types of ALK TKIs. So phase 2 lorlatinib demonstrated marked intracranial efficacy, improved progression-free survival, and very importantly, the resistance. The on-target resistance mutations were less because it covers almost all the types of ALK mutations as far as lorlatinib is concerned. So it eliminates clones, rare existing subclones of harboring ALK mutation. Therefore, you don't get an on-target ALK mutation. You may have a off-target mutation as an escape mechanism. This is the CROWN study. Phase 3 trial, nearly 150 patients in each arm. No prior systemic therapy, ALK positive lung cancer, asymptomatic or untreated CNS mets were permitted. More than one extracranial measurable target lesion should have been there with no prior radiation. So randomization 1:1, primary endpoint progression-free survival by independent committee and then investigator. The secondary, no crossover between the treatment arms. So the baseline were well balanced. Never smokers were around more than 50%, and then 50% were nearly women, nearly 60%. And this is the 18-month follow-up data, and this is how it is. The progression-free survival is not attained. Median PFS is not attained. Versus crizotinib is 9.3 months. So if you look into the Plateau, at around 24 months or even 33 months, and you just go into the number at risk. So like around 20 patients are alive even at 2 years. 20% remain progression free. And 11 patients, 4 patients, 2 patients remain progression free at nearly 2.5 years. So you can take alectinib as a comparator or ceritinib as a comparator, cross trial. The hazard ratio of 0.28 is not seen with any other TKI. So Dr. Nabakumar, looking into the hazard ratio of 0.28, look at the separation of curves and look at the plateauing of the curve. So how do you look at lorlatinib versus crizotinib? Lorlatinib versus the ALEX trial or the ASCEND data cross trial. So how do you look at the PFS?
Yeah, excellent data. So far, we have never heard of our HR of 0.28 in any other studies. So looking into the ground data, of course, the overall survival data is not available with us, and it is not a primary endpoint. But with a CNS metastasis, always the PFS is always the primary endpoint and looking into the data, when we go by the ALK trial, also the hazard ratio almost is 0.45 or something like that. So looking into that, it's a very excellent data, I think. So after alectinib, we have shown such a good result, especially in case patient with ALK positive and having CNS metastasis.
Very true. To see a hazard ratio of 0.28 in lung cancer in solid tumors is really impressive. And you can in fact see the number of patients at 1 year remaining progression free. Nearly 80% patients remain progression free at 1 year, which is phenomenal. So this is by the investigator. Again, here it's much better. Hazard ratio is 0.21, which was a secondary endpoint. And you can see early separation of curves. And then this is by the independent subgroup based on different parameters. You can see almost all the subgroups have benefited, irrespective of the histology, smoking status, age, gender, Asian, non-Asian, brain mets. You can just look into the brain mets part. The hazard ratio is 0.2. This is the response rate, 73 versus 58. Significantly better with Lorla compared to crizotinib. The duration of response is not reached. This is very interesting. The intracranial objective response rates. So 66% response rates intracranially, and in those patients with measurable brain lesions in the baseline, it's more than 80% intracranial response rate. Vis-a-vis crizotinib or crizotinib. So this is the time to CNS progression. I think this is the slide which we have to remember for today. You can just see that almost negligible patients had CNS progression. The drug goes on working inside the brain. So, Dr. Amit, how do you look at this? No CNS progression at all, almost negligible CNS progression.
I think it's a absolutely flat road over there. There is hardly, I think maybe only 1 or 2 patients who actually progressed. So this is something amazing. I mean, as the beginning of the talk, we said that this is something amazing. We never heard of. I mean, to be very honest, one of my patient also had the similar sort of history. Patient was in coma, and we started alectinib. It's wonderfully worked, but again he progressed very quickly within 3 or 4 months. So this was my experience with another drug. So if I look at this graph, this is something. I mean, we have to be very positive about this particular drug at this point of time. This is something. I mean, yeah.
I think the molecule is engineered in a very proper way. Otherwise, you won't get such dramatic results. And this is transferred to clinical.
No, we have never seen such a flat road in my entire life.
Yes.
I mean, this is nothing. I mean, almost zero.
Yes, I think really excellent. And look at the hazard ratio is like 0.07.
It's nothing, zero almost. There is nothing.
So this is the cumulative incidence of brain mets. As the first event, the cumulative incidence of CNS and non-CNS was lower in the Lorla versus the crizotinib. Again, hazard ratio is 0.06, and then hazard ratio for non-CNS is 0.3. So very impressive data. And then this is overall survival. So at the time of data cutoff, the OS data was still evolving. Hence, the between group difference in OS was not significant. Again, the hazard ratio is 0.72. But so I will go to Dr. Arvind now. So Dr. Arvind, there was a question in the chat box saying that why don't I reserve Lorla for subsequent line therapy? Because the OS difference we don't have up to now. I will give a first and second generation TKI, and I will reserve Lorla for subsequent lines because up to now we don't have OS data. So that's the question in the chat box. So you want to answer that, Dr. Arvind?
Yeah. The thing is that in any stage 4 patients, it's the quality of life that matters. And the graph which you show, that this is the graph to be remembered in today's presentation, I think that graph clearly depicts that the quality of life of the patients on upfront lorlatinib is there is no comparison between the other means crizotinib or the sequential. So even if the patients are lorlatinib versus sequential arrangement of the drugs like crizotinib, ceritinib, then lorlatinib, the survival is even same, but the quality of life, there is a hell and heaven difference. This is point number 1. And the point number 2 is that a fraction of patients after each line of treatment, they will be ineligible for the further line of treatment. The mutation which they will harbor, means they can't respond to lorlatinib. So at each line of progression, we will lose some of the patients who will be not eligible for treatment or who will not benefit from treatment.
True.
So
I think
this is
yes. Dr. Arvind made very clear points. I think we all echo what he said. So we are talking of lung cancer with brain mets, and the patient can die anytime, So if you are not treating properly, the patient will die. So in a metastatic disease with a deadly disease, you must give the best drug in the first line. Okay. If you're treating a patient who has a low disease burden, low grade lymphoma, that's a different story. But this is lung cancer, mortal. So if a patient develops CNS progression, as Dr. Arvind said, he may die even before taking lorlatinib. And one more, what he added was quality of life. The moment you have brain mets, the quality of life is always at stake. Brain mets is a trauma in quality of life, the cognitive impairment, loss of balance, falls, convulsions. These residual neurological impairment actually hampers patient's quality of life. So for these two reasons, you need to give the best drug in the front line rather than reserving it once the patient becomes crippled, both for quality of life and also not to miss any patient on exposing this wonderful drug. If a patient can afford, if the patient has a prospect, I think the way to go is to give the best drug that is active both inside brain, outside brain in the frontline setting. So these are the adverse events, reasonably well tolerated between the two. So we'll just come to adverse events and remember more the patients on lorla were on longer period than those were on crizotinib. So just focusing on those finer aspects of cognitive impairment, hypercholesterolemia, and so on. So now I would again go back to Dr. Moses. Dr. Moses, what have been your challenges as far as handling toxicity of lorlatinib is concerned?
The longest that I have used it for one patient is about 3 years. And it is relatively safe. I mean, apart from managing hypercholesterolemia and sometimes mood disorders, I didn't face much of a problem for that patient. So I mean, when I started out, he did have an episode of mania and suicidal tendencies. So we had to keep him admitted, stop treatment for some time, and then with the dose reduction, he managed it very well. And on the few other patients that I have used it, it's a very safe drug to use, and it's very easily tolerated.
True, sir. I think we also echo the same. Like it's very well tolerated. Lipid is a lab abnormality and not that is not clinically significant. And we can lower the lipid levels by giving statins. Moreover, CNS is an issue, like especially if you give lorla along with WBRT or immediately post WBRT, these patients have a lot of cognitive or behavioral disturbances or mood disturbances, as you said. We need to be cautious while giving WBRT. Otherwise, dose reductions would help CNS toxicity. We had a patient with brain mets, sort of leptomeningeal 2, we gave patient had mood disturbances, psychological abnormalities, and so on, and holding on for a little bit time, and then again giving it a lesser dose, the patient is doing well. So as you said, lipid and CNS toxicities is what we need to make note of. This is the quality of life. So significantly better quality of life than crizotinib, and this is the PFS. Again, not reached versus 9.3 months. So at 36.7 months of median follow-up in the lolatinib arm, the independent review committee assessed PFS remained significantly longer than lolatinib, and the median is not reached. 77.2 versus 58.5. So again, all the subgroups showing benefit as far as PFS is concerned. Again, with and without brain mets, even in a longer follow-up, impressive 0.21, 0.29. Time to intracranial progression, 92.3% remaining. Progression-free, hazard ratio 0.08. Is with brain mets and without brain mets. Both the subgroup, if there is brain mets, they melt away. If there is no brain mets, they won't develop brain mets. Impressive hazard ratio. And this is the intracranial response summary, very impressive, 70-65%. These are the adverse events that we were just looking into. And this is a safety profile, which we just spoke about. Summary of Crown trial, 18-month follow-up and 36-month follow-up. Reasonably well tolerated, only 7.4% patients required some. These are the key takeaways. I mean, we saw the data of PFS, 3-year follow-up data, everything. So now I will again go back to Dr. Navakumar. So Dr. Navakumar, the debate is always there, whether you want to use the first generation, second generation, third generation versus using the Lorla first. So you tell me tomorrow morning, if a patient comes to you with ALK positive lung cancer, cost is not a constraint. If you have brain mets and if you do not have brain mets, what will be your choice?
Yeah, but certainly we have seen excellent benefit in terms of CNS and ALK positive disease. We all know that always at risk of, even if the patient is not having CNS metastasis at presentation, he is at any time of at risk of developing the CNS metastasis. So looking into the scenario, especially with the ALK positive lung cancer, if the cost is not a constraint, so upfront, so the lorlatinib is the best option, seeing if the patient has CNS metastasis, and even if the patient do not have the CNS metastasis also. So I would recommend that if the patient do not have any monetary constraint, he want to have the best drug, so why not give the best drug upfront? Because similar things, the debate is also going on with the osimertinib also, and we have seen that excellent result with the osimertinib. So looking into the data that they have presented, so lorlatinib is the best way to go forward, I think.
Great words. I think these are take-home messages for today. That's the way we must think, actually. Okay, I think this we already discussed. First line setting with without brain mets we discussed, and this is all the options which we have, Lorla being there. And then this is the network meta-analysis comparing different TKIs, again showing that Lorla is superior to Crizo. Lorla is superior to other existing TKIs. Brigatinib has been also there. Again, you can see here these network meta-analysis, where they make an indirect comparison when you do not have a direct comparison. But Dr. Amit, how impressed are you about these network meta-analysis? You do not have head-to-head comparison, but these network meta-analysis come into play and they start comparing. So how much weightage do you give to this type of a statistical analysis in practice in the absence of head-to-head comparisons?
I think their network meta-analysis are important, but still, I personally feel the head-to-head comparison is always better to confirm the results. Because the trial constants are different, populations are sometimes different, that the whole strata is different. Sometimes the cohorts are Asian or non-Asian, or all the things matter. And what exact the ALK mutations with these patients have, I mean, you need to know the details, absolutely, to make sure that these are the actually confirmation. But in looking at this particular molecule, I don't think even if you do head-to-head comparison, my personal guess is this molecule is going to be a winner. Just look at the 3-year PFS. 3-year PFS is 2/3 of the patients are alive. And if I just look at the cross trial comparison itself, then both LX and ALTA, I personally feel, I think it was somewhere around 45% of the people are which were alive at the end of the 3 years. So big. I mean, even 20% difference at the end of 3 years, not 1 year, at the end of 3 years. So yes, these network meta-analysis give you some indication, but these indications are far very clear. I mean, this is not something. These are the flat, smooth roads. Almost nobody is who don't have any upfront brain metastasis is not developing anything for the next 3, 5, 4 years. It's a flat road, absolutely smooth. So I don't. I mean, it's not a great, not a. I mean, strange thing for me to see if there will be a head-to-head comparison in a phase 3 trial. There will be any difference of results. To be very honest.
Excellent. I think very good points from Dr. Amit. He mentioned all the important points of lorlatinib. So this is some similar continuing to the subgroup analysis. Again, lorlatinib looks superior in the indirect comparisons. So the conclusion is, in terms of PFS, the results indicated that lorlatinib was the best treatment choice for patients in ALK inhibitor naive or untreated ALK positive advanced non-small cell lung cancer. And then lorlatinib significantly improved progression-free survival than brigatinib and alectinib for ALK inhibitor negative in ALK inhibitor naive patients. No significant difference in the overall survival and adverse event analysis. Among lorla, alectinib, brigatinib, and crizotinib, lorlatinib had the highest probability to reach the overall confirmed response and intracranial responses. So, okay, so coming on, I think we did touch upon the adverse event profile. So just to ask the question in the chat box, again, I will now go back to Dr. Arvind. Dr. Arvind, if a patient has high cholesterol in the baseline dyslipidemia, is that a contraindication to give lorlatinib? Or how do you handle this situation of hyperlipidemia versus lorlatinib?
No, it's not a contraindication. If the patient is on patient need to be started on lorlatinib, then I go ahead with upfront. Generally, I add a combination of rosuvastatin plus rosuvas if 10 mg like that. I start. And generally, triglycerides, this patient has derangement of triglycerides while on lorlatinib, and generally they do respond to this combination of drugs.
True. So these lipid abnormalities are not acutely fatal. They can be controlled over a period of time with effective therapies. And they're not contraindications for lorlatinib, and they can be easily managed. And if you look into the clinical trial also, I think majority got controlled with conservative measures, and none required those, discontinuation just because of lipid abnormalities, and they can be easily handled in clinic. Okay, so again, very interesting question. Okay, I'll again go back to Dr. Moses. Dr. Moses, you can take up that question, So, what is your guess on the median PFS, looking into that plateauing of PFS? Any guess on, so crizotinib PFS is something around 10 months. If you go to the second generation TKIs, around 1.5 years. And what is your guess on the lorlatinib PFS?
So we have reached 3 years. So it's about 2/3 who have not yet progressed now. So probably another 3 years, maybe.
I think it should be
Yeah.
something around 2.5 years, nearly 2.5 years. I mean, that's a wild guess.
I mean, you can decrease maybe 5% every year by this rate, maybe. Yeah, somewhere down, I think at least 5 years minimum, I guess.
Okay. Okay, so I think we discussed all these lipid lowering therapy, monitoring, and so on. These are the different severities and how do we manage. And then this is CNS side effects, and then mild, moderate, severe. If it is 4, you will discontinue, or if it's 2 or 3, you will come by one level low. And okay, so now again I'll go back to Dr. Navakumar. Navakumar, so what do you do if a patient progresses on lorlatinib? Do you do a rebiopsy? And what are your treatment options? Liquid biopsy, you can take up all these questions. Patient progressing on lorlatinib, rebiopsy, liquid biopsy, what will be your treatment line and so on?
Yeah, we can go for rebiopsy. I think I will not go liquid biopsy. I will preferably like to go in this patient. And post progression, if patient is having limited metastasis or limited progression, then we can by guideline we can continue with the same drug and giving some symptomatic treatment to the patient. And if the patient is having clear progression with multiple metastases, then of course we have to go for some other options like chemotherapy in this patient. But with manageable disease, I think post progression, so with almost maybe 3 to 5 metastatic site, maybe we can go with the same drug with subsymptomatic treatment to the patient.
Thank you. Thank you. I think that's very valid. Then I think resistance pattern, this is how you would see with other TKIs. You can see the G1202R, that is a red one. And then this is the sensitivity of lorlatinib. It almost acts on all resistant ALK mutations. You hardly would see a on-target mutation. And these are the ALK dependent resistance mechanisms. You have NF2 loss of mutations. You can see the last row having rare mutations. And then this is the diminishing PFS. This is important again. So as Dr. Arvind was mentioning, the PFS goes on diminishing once you go more down the lines of therapy. You will have a diminishing progression-free survival. Therefore, better to give as early as possible. This is clonal evolution. As more generations of ALK TKI were sequenced, more monster ALK resistance mechanisms appeared. And this is the summary of everything. You do sequencing, you make the patient land up in brain mets, you give radiation, chemotherapy, rebiopsy, and finally put on Lola, or put him on Lola and forget it. The patient is going to remain well. So these are the ways to go, and these are the key takeaways. So again, Dr. Amit, what is your take on using IO post TKI progression?
Generally, they do actually, to be very honest, don't work. Mostly, if the patient is progressed on this thing lorlatinib, I personally feel that the other third generation TKI, maybe brigatinib or lectinib, basically these are after all different molecules. So maybe that, and even in the trials it has been proved that chemotherapy or other third generation TKIs are more useful in such scenarios.
Okay, so again I will go back to Dr. Arvind. What is the dose at which you will start lorlatinib? 100 OD or you'll start a lower dose?
Means the lower dose I can't get it. Means upfront it's 100 OD. I start with.
Yes. True. So if there is no other cost constraint, I would always start on 100 OD because it's a well-tolerated molecule, right? This is not alpelisib where you would expect hyperglycemia. So this is a safe molecule. You start with a proper dose.
Yeah.
So fine. I think we've completed the session. We answered all the questions. A very fruitful discussion. I would thank all the panelists for your active participation and sharing your opinion on this ground data. And I would
Thank you, sir.
thank
Thank you.
Pfizer for
Thank
this.
Sir,
Back to you.
actually, before to just close out, I just request your opinion on that the particular thing that you have already nicely discussing out. That post-progression lorlatinib, what would be the next treatment option? Sir, actually, as you also being updated that in ESMO 2022, there has been a paper presented where it has been seen that in the Crown trial further analysis, that those patients who has progressed with the lorlatinib, there are very few patients who has progressing further with the ALK resistance mutations. Other than the ALK resistance mutations, the other mutations, the chances are very high. So although you know that the ALK resistance mutations after the lorlatinib progression is very less, so what would be your takeaway or what would be your opinion on it? And also,
I think Dr. Amit and Dr. Nabakumar already answered. It's we do not know. So to be honest, none of my lorlatinib patients have progressed up to now. So they are remaining progression free. What I did for a patient, for a patient off label, because of cost, I gave 25 OD. The patient did so well for 2.5 years, and then I put him on PEM carbo with Lorla. I continued Lorla, the lower dose. The patient is holding on. So I think chemo is yes, but rebiopsy to look for non-ALK mutations or to look for ALK mutations that may be sensitive to earlier generation TKIs. And as Dr. Amit said, I will not use IO. IOs do not work in this space. Chemo or look for other rare targetable mutations. And I'm very skeptical in using earlier lines of or earlier generations of ALK inhibitors because Lorla is a pan-ALK inhibitor. So, Dr. Arvind, do you have any opinions on what is post-Lorla progression?
Post-Lorla progression, I agree with you and my other colleagues that no IO. Go ahead with either combination of chemotherapy or other ALK inhibitors. Check the resistance mechanism. It is ALK dependent or ALK independent. And so further we can go ahead with other ALK inhibitor or a combination of chemotherapy.
Sir, I have one small cohort analysis with me, and that shows that people have used the combination of other third generation TKI after lorlatinib progression and chemotherapy. And what they find is there was maximum response rate was other third generation TKI. That is 29% of the patient responded after lorlatinib progression. And with chemotherapy, it was 16.7%. So definitely I think some cohort analysis has been telling us that maybe
so correct. Some ALK inhibition should continue. That's the point.
Yes.
Excellent. I think Amitabh, we could answer those. Dr. Amit
yes, absolutely.
picked out the cohort study. Yeah.
Yeah, absolutely, sir. Thank you very much. And sir, most of all that you have answered all the questions in a very nice way. Also, sir, just a last one, if you just ask also your panel members that already we knew that once the patient is progressed with the other line of treatments in the brain metastasis and patients is already having certain symptomatic brains lesions. So in that case, sir, how to distinguish the lorlatinib-induced CNS adverse events to that particular patient who is already having certain type of brain metastatic symptoms, sir?
Well, brain met symptoms are pressure related. The patient can be drowsy. The patient will improve with DEXA and so on.
You give steroids and you will
Yeah,
check.
if you give DEXA, the patient calms down. The patient doesn't have a weird behavior, Whereas with Lorla, the patient starts shouting around. I had only one patient. I was, there was a prescription from somewhere, and I said, no, the way to go is Lorla, and I forcefully gave Lorla, and that unfortunate patient landed up with psychosis, and the relative was looking at me in a very skeptical way. It's very difficult for me to defend. So, you don't see those involuntary movements. You won't see psychotic behaviors, mood disturbances. Rather, you would see neurological deficits, which would promptly improve with dexamethasone. Yeah.
Right, sir. Thank you very much, sir. And last, I just request you to just give a vote of thanks, concluding remarks for out of this particular today's discussion, sir.
Yes.
If you want to just.
So, well, we are speaking of a molecule. I think there is no second molecule, at least in solid tumors in oncology. This is one of the molecule of its sort. I think all of us acknowledge that we never saw a molecule that is so very efficacious. We saw nobody progressing, excellent CNS activity, and the key is do it as early as possible, if possible in the first line, and don't wait for the patient to have brain mets. So we are very privileged to speak about this molecule, to have such a great efficacy. And I would thank all the panelists, they really gave their valuable inputs. It was really enlightening to listen to all of them. And I would, I would be keen in much more meets on the updates of lorlatinib, post-Lola progression. These educational events would be really helpful for us. Thank you. Thanks, Pfizer, and thanks all of you. Yeah.
Thank you, sir. Thank you very much
May
for
I-
your presence today.
May I
And I
request
would also
Sushovan?
like to
May I request
hand over to Vishwa. So for the vote of thanks, sir. Yes, Vishwa.
Yeah, may I request Sushovan to come online, please?
Yeah, good evening. Thank you very much, all the panelists and faculty. And it was a nice presentation and elaborate discussion. So nothing to say. Vishwamitri, you can just go to vote of thanks and we can close the meeting.
Sir, on behalf of Pfizer, once again, it was a academic feast, I say, to be very precise. And thank you for all your active participation. It's great to see the advocacy building around lorlatinib. My sincere thanks to all of you. Wish you a very good night. Thank you. And we'll be conducting this sort of meetings again and again. So we'll be looking forward to your active participation on those meetings. Thank you very much.
Thank you, everyone. Thank you.
Good night. Good night, all of you.
Thank you, sir.
Good night,
Thank
sir.
you.
Good night.
Good night.
Thank you, sir. Bye, sir.
Thank you, Kia. Thanks for conducting this meeting.
Yes, sir. Welcome, sir. Thank you, sir.
Thank you,
Thank you, Vishwa. Thank you for inviting me.
Thank you, Dr. Amitabh. Thanks, Sushovan.
Bye, sir.
Thank you, Mr. Uttam.